we're going to be discussing the case study that we distributed last week in class. And so today will be an opportunity really for you guys to drive the conversation as we go through that material. Before we begin, just a couple of things. I believe all three of us will be on the line today, but if you have any follow-up questions or other things that you wish to interact and discuss with us, you have our contact information available to you in the presentation. Today's session is going to be on the case study, and then in 2 weeks, on March 7th, we'll actually be going deeper into best practices for attribution and activation. Today is very much focused on the data attribution process and less so on activation. But as you'll see in the coming weeks, we will start to shift gears away from the basic attribution process and much more towards activation. Please remember, we will have a sign-up web link for you in next week's session that will allow you to sign up for a one-on-one session with our team. The purpose of that session the purpose of that one-on-one session is to talk through with you some ideas for the group projects, which will be presented in the 6th meeting, in our final meeting on April 18th. I don't want anyone to be worried. It should not be, it's not the type of project you're going to have to spend exhaustive amounts of time on, but just an opportunity to get you thinking about how to put this information into action. So you'll have a sign-up link next week, which you will be able to use to communicate the best time for us to meet with you. In today's discussion, we're going to be quickly going through some information from the homework last week and talking through the types of attribution data that you may receive from your payers. The case study looks at 3 very specific types of data that are actual real life, with the exception of being false names whenever we had patient-level data, false names and medical record numbers and dates of birth and what have you. They are, in fact, real data sets that are provided to safety net providers for the purpose of value-based reimbursement. One is the basic data that comes from the Medicare Shared Savings Program. The second is some periodic attribution data received by a federally qualified health center in a Medicaid ACO-like program, and then we have a look at some very short list but detailed claims data to kind of think through how that might work. And today's discussion, the majority of the session will be focused on discussing essentially how to get the most out of this data. We will have some really light homework for you before session 3, and that will bring us to the conclusion of our discussion today. So we asked you in the homework what some of your challenges were as it related to the process of linking the payer's patients to your organization. And some of the feedback we got was that you received, a lot of different types of requests for payers. Some of it was non-structured data, and so there was a lack of efficiency in kind of interacting back and forth between the plans. The data quality, in fact, can be problematic, and there's no kind of better evidence of this than when the data indicates patients that have moved on are no longer covered by the health plan any longer, or in some cases are deceased. Payers also don't have, many payers don't have any type of mechanism for attribution data. So, in most cases, those are in situations where the payment mechanism isn't necessarily dependent on making a linkage to a provider. And I think that'll be, probably very likely true, especially for our folks in the oral health world. Much less so in primary care, but on the oral health side or on the hospital side, and I think even in the Indian health world, they may not be doing this yet. They may not actually be providing you with any sort of attribution data. It's really more kind of a reactive process in terms of how you bill and get paid for those patients. Are there any other challenges to getting and using attribution folks wanted to discuss? Okay, well, today is going to be all discussion. So as we get to the case study, I'll actually have to start calling on folks if we don't have enough interaction. In terms of, we asked what were some of the basic activation strategies that folks utilized. And we got some great answers in that regard. And I think that this will be an area that we'll want to look at as we dig deeper into the topic of activation. One of the most commonly cited strategies was the utilization of non-clinician physician extenders, such as health coaches and care coordinators. Quite a bit of information was provided on the education component, meaning the availability of education tools and education resources for patients to be able to continue their care post-visit or post-treatment. A lot of focus on much more collaborative treatment planning, so patients and their families being involved directly in their care. Periodic patient questionnaires to measure perception of progress and essentially determine whether the patient remains kind of activated and an active participant in their own care. And then the proactive outbound kind of scheduling of patients when either disease or other factors would suggest the need for regular or periodic follow-up. Any other activation strategies that folks wanted to discuss? Okay, very quiet group. Let's move forward. So today we're going to be discussing the attribution process and the types of attribution data that organizations receive. Attribution, as we discussed in our last session, makes a formal linkage of a patient and therefore that patient's outcomes and costs to a provider organization or network of provider organizations. And what we mean by linking their costs is that when we study essentially the cost trends for that patient, the attribution process in essence allows the plan to make some claim that that provider organization or network of provider organizations is the one that's responsible for the outcomes associated with the total cost of that patient's care. That doesn't necessarily mean that the patient received all of their care from that provider, but in fact that provider could be held accountable for the sum total of that care. And that's a very important thing to understand about virtually all value-based payment mechanisms that link cost as an outcome of the care that you provide, is that there needs to be this formal process of making this linkage in order for it to work. A couple of things that we'd like to point out. Attribution is usually impacted by upstream issues. For example, the patient needs to be assigned or eligible for the insurance product at the time of attribution. Sometimes there's requirements that the patient have had continuous coverage for a period of time. In, for example, the Medicare Shared Savings Program, the patient needs to have been a participant on Medicare for the previous 3 years. They may be eligible. There may be issues around their eligibility for a specific contract. So they may fall in a different plan under which you have a different contract or different value-based reimbursement methodology. And some patients may have the ability to opt out of certain programs. Medicare has actually removed that eventuality from the ACO program, but other contracts may theoretically allow patients to opt out of a contract. Generally speaking, a patient can be attributed to one and only one provider, organization, or network at a time. And that's because the plan in health plan or Medicaid or whomever the payer is trying to make that distinction or connection of the patient to a single provider for which to hold the outcome. There are some exceptions to that, but generally speaking, that's kind of how this works. If the plan is to pay a bonus to a provider or organization, they intend to pay that bonus really only to the one provider organization that cared for that patient. It is for this reason that in many parts of the country and in many environments, organizations are coming together under umbrella organizations like ACOs to do this work, because in theory that ACO then serves as a vehicle that allows them to redistribute those bonuses amongst the multiple providers who may have cared for a patient throughout the life cycle of care. A patient may be attributed due to the presence of a historical caregiving relationship. We call that retrospective attribution. They may be assigned based on certain assignment rules, or they may be assigned because the patient proactively selected that provider when they enrolled in the insurance and in the plan. So our framework for using attribution data really asks three fundamental questions about attribution data. And we're going to use these three questions as we go through the case study today. Does the data help us understand how and what we will get paid? So if, for example, we're operating under a primary care capitation payment, which means we receive a monthly payment for each patient to provide care for that month, well then certainly attribution data is critical in understanding what we're going to get paid. We need a list and a number of patients to justify essentially the money coming in to the organization. That's one example. Does it help us develop clinical programming? So can we look at data about the attributed population and have any sort of indication of what some of the underlying needs of that population are? And therefore, does it help us prioritize our resources? Can we use the information about the underlying population to make good decisions about how to care for and hopefully keep that population healthy? So in many ways, attribution really is the beginning of the skill sets necessary for all value-based reimbursement work. We're going to use these three questions as we look at the attribution data. I'm going to quickly talk about the basic attribution data. This was the first set of data that you received. And it's basic attribution data usually provided by CMS for the Medicare Shared Savings Program. This is an exact report. We changed some of the names and numbers, but it's exactly the information that an ACO would receive within the first month of having an attributed population to them. And in this program, the organization participating is asked to manage quality and cost with the hopes that if they're successful, they can receive some significant portion, 50 to 60%, of any savings they derive against a predetermined benchmark. This is very basic data, as we'll see, because the data itself does not list individual patients. It, in fact, only lists things like counts and record numbers and number of patients within certain subcategories. So with that, I wanted to turn it to you folks and ask if you had put some thought into this. What information did you find this information to be useful, and what type of information could you glean from it that would help you, in doing your work?
This is Amber from the Donation.
Oh, go ahead.
Yes. Hi, Amber.
Hi. I just wanted to say that we found this information very helpful, not useful per se, but based on the way we're paid and structured, we don't have any of this yet. We don't have any type of attribution or activation. So it was good to sit down with our billing team and just take a look at how we could use this. If we received this, how we would do anything with it. So just that scenario in general was helpful for us to see what other people might be getting. So that was our first take of it. Just
great.
to see what is out there. Yeah.
Yeah, great. Was there someone else?
This is Kevin Goss from Community Health Center of Yavapai. You know, one of the interesting things was us trying to figure out what type of attribution model we have with our payers. So from this first data set, it looks like to us they're using a plurality attribution method.
That's correct.
And then we a note that we put was that this data could help us prepare to reach out to the excluded beneficiaries who are receiving a plurality of primary care services elsewhere.
Right.
So,
yeah, that's a great point. And when we look at more patient level data later, one of two things actually that that organizations operating under this program do that help them be successful is, one, make sure that they can, that they know all the patients, that they can identify them in their systems, and that they all have kind of up-to-date care plans, because these tend to be fairly care-intensive patients. And the other thing that they do, Medicare, in this case, Medicare essentially allows for one and what they call an annual wellness exam, which is essentially similar to like a level 5 comprehensive primary care visit. And what they're doing is they're actually proactively scheduling folks into those visit slots because the visits, they pay reasonably well. So there's a positive financial benefit for doing it. It gives them an opportunity to better manage the patient's needs in a kind of a proactive, intentionally designed kind of for comprehensive care. And lastly, and not least, is it helps ensure that those patients don't fall off their roster in the future years. Because if you're managing these patients, you want to maintain them on your roster. And so by having that annual wellness exam, it really does help. You are correct, the plurality model, but in ensuring you have at least that one annual visit certainly does help keep folks on the roster. So good observations. I found this table to be fairly interesting. I know you probably can't see it super clearly on the site, but this table actually talks to the percentage of patients receiving the number, a certain number of their visits, or percentage of their visits with the organization. So again, this kind of gets to how much time are you spending with this population? Do you really know who they are? Are you really proactively managing their care? Or do you need to formulate relationships with folks outside, providers maybe outside of your network, because they're playing a key role in caring for those patients. I was going to stop at this table and ask if folks had, put any thought into some of the things within this table here, Table 2-4, that provided some insight into challenges, specific to the safety net, and any findings here that you thought were interesting.
This is Teresa at PCHC in Maine. I guess what we sort of took away from this table, very little end-stage renal disease with that population. A significant amount of patients who are disabled, but definitely not as much dual. So likely not as many poor disabled individuals, but a fairly good-sized number of elderly patients. So it was just helpful to sort of break out the Medicare population there to see what you were working with.
Right.
If this were our data, then obviously we would be, attacking that population much differently than what we currently have, where, we've got about 35 to 40% of our elderly patients with Medicaid as well. So they're fairly poor disabled individuals.
Right, and that comes through here if you see the age dual eligible being about 12%, maybe a little less than 12% of the population. Yeah, 11.48, I think it is. And that's likely to be a lot higher, at least in our experience, in a safety net care setting than not, because those dually eligible Medicaid, Medicare patients are probably, in many cases, are in the communities where you folks operate, and may seek, your setting of care as being important. It would be quite a bit lower typically in a non-safety net setting. We usually see that number much lower because we know the challenges essentially of finding physicians who are able to care for Medicaid patients. End-stage renal disease is an interesting finding here. I think we look at some of the costs associated with it. Even though those patients, there's only 25 patients there, those patients on average tend to cost about $80,000 to $100,000 a year because of their disease. I wanted to ask if any of the groups had any specific programming around treating patients with kidney disease or dialysis-dependent patients. Is that an area of focus in any of your organizations?
It is not here at Community Health Center of Yavapai.
Okay.
Nor is it Worcester really focused on nation.
Yeah. Okay. Yeah, that's it's a challenging population, of course, and one that does have very special and significant needs. It is also an area, again, because of the high cost, where networks like this under a value-based payment arrangement might seek to put some special resources around, because there's opportunity, there's quite a bit of financial opportunity there. This table here identifies which patients fall into which HCC groupers. HCC groupers, we don't do an exhaustive explanation of them, but essentially it's a Medicare risk adjustment or risk scoring concept that helps determine which patients are really most impacted by which diseases. It's kind of a prioritization that is actually used to be somewhat predictive of the patient's cost, and it does so by identifying all of the diseases that the patient has based on billing data, and then assigning them to one and only one HCC grouper. You'll notice that there's quite a few things here, I think, that could be of interest to folks. I wanted to ask if anyone had any thoughts about how they might work with their clinical staff around this type of data and using this type of data as they started to prepare to operate under a value-based purchasing model.
So this is Teresa from PCHC. So this probably was one of the more useful tables, I thought. It was really helpful to sort of compare, the rate or the per thousand or per 10,000 rate to your peers and look for any outliers. So for us, what we identified in this group was a lot of substance abuse and mental health, much more than you would see for their peers. And so it could be two things. Maybe that particular safety net organization has, integrated behavioral health, so they tend to see patients and identify them more and provide that care. Or maybe, these patients are going elsewhere, and if they are going elsewhere, it may be an opportunity for a new service line or a way to improve collaboration and communication to better manage that population.
Right. Excellent findings, yeah. Any other thoughts on this one?
This is Kayla from Cherry Health.
Yep.
What I noticed looking at this sheet is that it reflects the focus of some of our special projects that we're doing. So, and I think this is how they come up with these special projects in certain areas. So those conditions like COPD, heart disease, diabetes, depression and anxiety are things we focus on, and that's because if you use information like this, you can identify which groups you really need to focus on because you have a plethora of them available. So I just was drawing some of those connections between things we focus on from different levels and how it's connected to this sort of data.
Right. Excellent. Yeah. Interestingly, in just scanning some of them, not a huge disparity essentially between this organization. If you look at the rate per 10,000 and others, maybe something interesting going on there in that they seem to have more patients that have no HCCs, which would be kind of a lack of any sort of chronic disease. That's kind of an interesting finding. But you certainly see some variation. The septicemia you see is nearly half. Is that a sign of good care, or is there maybe something else going on there? But certainly, I think this creates a foundation for having a very different conversation about how an organization essentially plans to administer care, and I think can immediately start to get us thinking about where we may or may not need to readjust or reallocate our resources. You're going to see in the third data set, you're going to essentially see a much rawer form of this information, one that in theory would allow you to do quite a bit more. But this is the type of summarization that in our experience really do kind of get the kind of creative juices flowing as a team is coming together to study how they could operate better, how they could organize differently, and without even seeing a single patient's name, how you could in theory be starting down the process of taking action. Any other interesting findings that folks had in exploring this first data set that they wanted to share? Does anybody get this type of breakout? Yeah, go ahead.
Yes, this is Theodora Anderson Diaz from First Choice Health Centers in Connecticut. And I'm just wondering, because I'm looking at the slide, and I'm just wondering how there was a person who spoke beforehand that talked about plurality, and I'm trying to look at that and trying to see what was the logic behind that made that person conclude that it was actually a plurality attribution.
So if you look at this first table 2.1, what it's showing you is essentially it's a two-step process, and we went into a little bit of detail in this in the first lecture. It's a two-step process. So that first number under total, that was the total number of Medicare beneficiaries who had at least one eligible visit to the organization in the previous 3 years. And what you see is that number starts to come down for a variety of reasons. ACO did not provide a plurality of primary care services being the first one. So 488, it looks like, of those patients actually had more primary care somewhere else. And that would be a very interesting thing to explore because that's a fairly significant number of people. And in this case, this was a federally qualified health center driven or made up ACO. They'd probably want to know why those patients were getting so much primary care elsewhere. Keeping in mind, and again, we didn't get into all the intricacies of the model, but certain specialists do qualify as, they're considered primary care even if they are more what we would consider more of a specialist. Cardiology comes to mind, so a patient that sees a cardiologist 5 times a year, they're just likely going to get, attributed to that cardiologist if they're only coming to you once or twice. Is that helpful?
Yes, thank you.
Yep. Other thoughts before I move on? Okay. I'm going to do a quick recap. This was one of our kind of our very early organizations that we worked with on this program. And they, I wanted to kind of tell a little bit of their story and give you a sense of what ultimately happened. They used this data, they found this data to be very interesting and used it to facilitate some very important questions. They convened, this was an immediate reason for them to convene kind of an interdisciplinary working team between finance and physicians and other clinicians, including nurses and the like. And they immediately picked up on some things that they wanted to work on. One of them was they were interested in discreetly identifying the Medicare beneficiaries who were eligible based on disabled status. So those are people who typically are under 65 but have a disability, because they felt like they were pretty well equipped to address those patients' kind of unique needs, but wanted to basically get them in and really make sure that everyone had a thorough kind of, care planning type session, especially if they were using the clinic primarily for urgent care. They wanted to kind of reverse that and really get that annual wellness exam done and build a kind of a self-directed treatment plan. They were also interested, even though there were only 25 patients, they were very interested in that end-stage renal disease population. They did not have, like most of you said, they did not have any kind of special focus or program for the end-stage renal disease population, and they figured that they might need to look into that or learn more about it. They looked at the relative prevalence of disease, and that was one of their favorite things to do. They spent a lot of time doing that. We facilitated and worked with them in doing that. They were very interested in talking about who had the sickest patients. They were very curious with some of those findings and found it to be almost fun to kind of pick through and understand that data. But they did actually get down to some immediate things they wanted to explore further. Who were the patients that were using a lot of outside primary care, and could they rein that in? Or did they need to form deeper relationships with those providers? Why were there some people who were utilizing primary care 20 or more times? They were very curious, that was one of the data tables, who those folks are and what were their unique needs, and was it appropriate that they were seeing primary care 20 times in a year? And again, could they do something unique to improve the status of that end-stage renal disease population? The reality, though, was that this was interesting information, but at the end of the day, they wanted to go a lot deeper. And so they needed information that was going to be more actionable. Specifically, who are these patients that make up this population, and what do we know about them in order to essentially make them healthier and work towards the goals of the payment arrangement that they had with the plan. And as you'll see later when we look at raw claims data and what that looks like, they in fact did receive a lot more information and data later. So this was kind of an appetizer for them, but certainly something of interest. And I'd be curious and would encourage you folks back in your practices to find out if there's any sort of kind of comparable summary report already available to you from your payers, and if not, if that would be something that they would be interested in working with you on, especially as you start to explore value-based arrangements with them. Let's move ahead. So the next data set is periodic attribution data. And these are, this is precisely the data that this organization receives, and they receive it every single month. In this model, they are a non-managed care state, or were at the time of this value-based program. Therefore, they worked directly with the state to develop a model in which they received some care coordination payments for an attributed population of patients. Very similar to a medical home, a patient-centered medical home type payment model. The patients on the list each month represented all of the patients who are eligible for the program and are attributed to the provider organization as of the beginning of that month. And therefore, they are eligible for any bonuses based on the number of patients awarded to them for that month. So it does shift from month to month for a variety of reasons. The patients are assigned to the provider organization based on a best fit model that Medicaid uses that's based on the geographic location of the patient. So patients are not assigned to an organization if they come if they have to travel, I believe in this state it was 30 miles or more. That's going to vary based on the nature of the geography, but 30 miles was considered to be too much of a hardship, so they would be assigned elsewhere. Patients are dropped from the list if they lose Medicaid eligibility, if they choose another provider, if they move out of the region, or if they pass away. And the organization is eligible for a per member per month payment for each patient on the roster. All other gain-sharing bonus payments are made for the populations of patients that have no lapses in coverage for the entire year. So they get a monthly PMPM that is essentially a reward for operating like a medical home. And then at the end of the year, they receive other incentive payments, but those payments are tied to folks that were on the roster essentially for all 12 months. This organization has, on average, about 6,000 patients on the report. We only gave you a small snippet of the data. That was intentional because we just didn't think it served any purpose to give you the full list of 6,000 patients. But we want you thinking about how you would manage a much larger amount of data than a single page. This is all they get. So this is the only information that Medicaid provides them at this time. So as you think about it and as we discuss it, you'll want to kind of figure out how the implications that not having any additional data would mean. So let's start by talking a little bit about the data itself. I think it's actually fairly straightforward. We're pretty, used to this information. And I'm going to start by asking, do you guys feel like you would have this data manipulation skills and ability to kind of take this data and put it into action? What would you consider doing with it if you got this data from your plan?
This is Mike with Worcester County Health Department. I was really interested that I liked that it had a zip code column because we have multiple offices, so it might be interesting for us to look at what natural supports are in the community in different regions, as well as what services should we be doing at which sites. The data like this would help us to kind of see where a multitude of our clients are coming from, so we know sort of where we need to beef up services, essentially.
That's great. Yeah, I think that's an excellent point. Any other thoughts? Thank you for that.
This is Teresa at PCHC. Similar to our Medicaid population here, we have patients who are on and off the program a lot, so there may be times when they actually are back on the Medicaid program and we aren't aware of that. They were uninsured at one point. So having sort of the Medicare numbers and this attribution monthly would be a way for us to populate that information. It also gave, phone numbers. With this population, sometimes it's hard to keep an active phone number. So if this didn't match the one in our EMR, it may be an opportunity to have better contact information for outreach. Again, I did like the zip code piece to be able to break it out based on site. For us, this would be helpful for billing. Like you said, if we were getting a PMPM, to be able to make sure we were getting paid appropriately, but it's not really helpful for outreach. So if I, wanted this information by disease process or by risk score or anything that would allow us to target for outreach or care management, that this doesn't really lend itself for those purposes.
Right. So that's, that's kind of where I was going with it is, this is pretty, when I said this is all they get, it's pretty limited. It doesn't tell you, unlike the first report, which didn't give you the names, but did give you a lot of information about the underlying disease, this gives you nothing that looks like that. It's really just kind of administrative type data. Let me see if someone else wants to chime in here. Do you feel, I'm really curious to know, based on kind of your in-house staff, would you have the ability to take these six, because you couldn't do it by hand. I don't think anyway that you'd want to be trying to do something like this by hand. But would you have the ability to take this list and hash it up against some of your internal systems, either your electronic health record system or your practice management system, whatever that system might be? Is that something you guys feel that you have the ability to do, or is that something that you would feel would be more of a a new challenge that would arise from something like this?
This is Lauren with Worcester County also. We have an internal IT department who could probably take the list and bash it up against a report generated from our EHR.
Yep.
It's been many, many years since I've done that specific act, but yeah, I'm sure we could figure that out, if not with filters or something like that.
Yep. Okay. Okay.
This is Amy from the Chickasaw Nation, and the software that we actually utilized with our grant funding, Midas, is a software that we could create patient panels and do some forecasting and things based upon this data with that software.
Cool. Okay. So you could actually put these folks into a panel almost based on their appearing in this list.
Correct.
Yeah. Okay. Great. Great. Was there someone else?
This is Ariel with the Gary Mary West Senior Dental Center, and that was actually one of our questions because we haven't done, we haven't been attributed yet to any health insurance plans, and so we were wondering what people were using to be able to do this because we have an external IT department and our administrative staff is very small, so we were looking at it as a very large data set and kind of wondering how people were reconciling it month to month since you're looking at it on a monthly basis but not seeing how, each patient carryovers to know if you're going to be getting that bonus. And so if people were using macros in Excel, if they were putting it into some kind of statistical software, or we have Open Dental because we're just oral health, if there was a way to kind of work with Open Dental to get this data so it could, provide the outputs that you're looking for.
Do some of the folks want to comment on that, how they're doing it, what tools?
Our Midas software system, you have the ability to create panels on many different things, and right now we're using it to create panels for each of our providers, and as we have them in panels, not by payer, but we impanel our patients to take a look at forecasting. Case management uses it to kind of look at preventative health things when they're needing appointments and how they're accessing our system. So it really is, we have the ability to just, if it's in Excel, we can just copy and paste into our Midas software to create that panel.
I see. Okay. Any other approaches that folks are using? So I'll comment a little bit, having worked with a number of organizations who have done this. I think that you kind of the first set of tools that most folks, I think, really start down the road with this. It tend to be more of your kind of commercial spreadsheet type desktop software, and of course that's a good place to start, but has rather significant limitations. But for example, you could theoretically look at appending some columns to this that would tell you something about each patient's kind of relative risk, whether they had certain diseases, whether there were phone record mismatches. But you're going to max out that software pretty quickly. Access as and I apologize that I'm using real product names. I'm not endorsing necessarily any of these, but Microsoft Access, for example, is a desktop database software that could actually theoretically create more capability. But most organizations that are getting kind of deep into the value-based reimbursement world are tending to use more SQL-style database engines. And there's a variety of them out there, including some that are free. And that just allows them to do a couple of things. One, it's a lot more robust. It can handle a lot more data. They tend to, process data information much faster. They also have quite a much more stable and comprehensive set of security tools. So you can you can store the information instead of on an employee's local laptop. You can store it on a server with password protection and the like. And that really we feel is the level of skill that we think most organizations are going to need to have. We feel at some point having somebody either on staff or that you can tap into that can do some fairly sophisticated SQL, which is structured query language programming, is probably where most organizations are going to go. Then you heard some folks say that their EHR tools or other tools have some of that capability built in. And we're starting to see more, of that emerging, particularly as value-based reimbursement methodologies are propagating throughout the country. But the most sophisticated approaches we've seen are to actually purchase, and they can often be very expensive, so they're not as widely adopted at this stage, analytic software packages that are specific and customized to kind of the healthcare landscape. So that seems to be the trajectory people are going down. Part of the reason we wanted to actually have this discussion was really to get you thinking about what you might need, even if you're not yet in these types of models, that you certainly could be at some point in the future and would want to rethink that. So I hope that was helpful.
Yes, thank you.
So I'm going to kick us off. We're going to go through strengths and weaknesses. How would you use it, which I think we've already covered in pretty good detail. What other data would you combine it with? Are you prepared to do this today? And then I'll take you through kind of how this group operated. The obvious weakness that I think all identified in looking at this data is it really doesn't tell you anything about the patients. It just tells you that they're yours, that they're on your list. Unlike the first data, it did not tell you how frequently you've seen them, what kind of diseases they had, if they were seeing other providers with any kind of frequency. And so it is almost, I'm not going to say entirely, but almost useless without being combined with other data sets. The strength, though, I think you guys hit on the head, is it did give you some information that would serve as important links to your existing system. So it had a medical record number, it had date of birth, it had zip code, so you could probably pretty quickly address the potential for overlaps and duplication and mismatched patient records with relative ease. One of the things that you might not have picked up on that I'll talk about when I do the recap, that's a real weakness of this data, is that it doesn't proactively tell them when patients are dropped off the list. Each month they just get a new list. And so there's they had to do some fairly significant data manipulation to identify what they consider to be one of the most important activity that they wanted to undertake, which is finding out why patients were getting dropped off the list and making sure they got re-added as quickly as possible. Oftentimes, what they found is that the patients were dropping off the list not because they were no longer their patients, but in fact because their Medicaid eligibility had lapsed and they needed to renew it in order for them to both have insurance and to stay covered. So a critically important function that they wanted to provide, but the data in and of itself did not give them that. That was an extreme weakness in this case. We'll talk about how they overcame that in a second. I think you guys did a nice job of talking about this. Generally, you would want this to be a panel of some type that you could reference and study outcomes associated with. You would also, someone said, it would be really helpful from a billing standpoint because it helps to reconcile those payments that actually got made. And when they had the, bonus at the end of the year coming up, they really needed to use this list to understand the clinical indicators that went into that list. Actually, interestingly, I didn't share the actual measures. One of the things they can receive a bonus on is if 70% of the patients on the list actually had one wellness exam in a given year, they received a fairly substantial bonus. So that was certainly something that they wanted to use. So in our, the next part of the discussion, what data would you need to combine it with? For them, it was really important to identify which patients had chronic diseases, which would include them then in the denominators of certain quality measures. They also wanted to combine it with last known non-urgent visit. So when was the patient last seen in kind of a more comprehensive visit setting? They needed to link based on Medicaid number. They actually found a fair number of patients that didn't show up anywhere in the systems, and they had to reconcile how that was the case. But generally speaking, I think you guys did a nice job hitting on some of the data elements. And then last thing was, are you prepared to do this work today? And I think we've heard everybody seems to have some capacity and capability, but maybe a little bit more variation than we'll probably see in the coming years as all of our organizations kind of go through this transformation. So in this particular case, I mentioned it was a group of safety net providers that came together under an ACO-like umbrella, and the network took accountability for really wanting to get this data into the hands of the care team. They actually created a separate database for doing that, and it allowed them to kind of quickly and efficiently take this data, load it into their database, and then compare it to the EHR and practice management data, which allowed them to do that prioritization and therefore support outreach to patients. They actually did spit back a risk score, a very simple risk score, something that indicated whether the patient had certain chronic diseases that were of interest, as I mentioned. And once they built that infrastructure, which was all done in a kind of SQL-style database, as I mentioned, they were able to create a set of important reports that went out to the care teams on a monthly basis. The drops who were then called to verify, and typically it was a Medicaid eligibility issue, so they'd get them re-enrolled, but they really wanted, that was a priority every month. The teams had to see the drops. And then the ads, because what they were finding is that they were getting a lot of new patients showing up on the roster, and they wanted to figure out how much of a priority it was to get those patients in, because the data in and of itself did not, give them any sense of the needs of those patients. So they actually set up a process of getting those patients assigned to one of their physicians, and then getting them scheduled for an appointment, kind of as soon as available. But they did so with a phone screening process to get a sense of how complex the patients might be and any special needs they might have, and therefore what the priority was for getting them in. And then lastly, as we discussed, this became the report by which they reconciled essentially the payments that were being made to the network in order to understand whether they were being paid effectively and efficiently. Any other thoughts folks had before we move on, or questions that you might have about this data set? Okay, we'll move ahead then and talk about really the final frontier, as I like to say, of attribution data. We still, to this day, don't see a lot of organizations receiving detailed claims data, and even if they do, we don't see a lot that have built out extraordinary skill sets in how to manage it. But this is, in our opinion, where the relationship between health plans and providers is likely to go over time, is really a robust sharing of information so that the provider can play an even bigger role in helping to care for the population. We have provided you with a very small snippet of data. Again, we mocked up the names, but this is essentially exactly what our real organization is receiving. We've only shown you one patient and one type of procedure, which is an ER usage with no admission. But in theory, this data set, which was roughly 65,000 records in each file, explained and described every single paid claim or transaction that the patient undertook. So you could see all sorts of things like facility utilization, like drug prescription fill information. You could see which specialists they were utilizing. You could see a bunch of stuff, durable medical goods that they were receiving. We asked you in the case study to assume that this data was provided on a monthly basis with 12 months of trailing data and a 3-month lag. So that's pretty typical, to be frank. because, as we know, the different insurers have different filing deadlines. So what the insurers will typically tell you is they only want to share what they call adjudicated claims data because without doing so, there could be a variety of reasons why the information is wrong. We tend to push back on that and say we'd rather have some potential that there's some misinformation in there, but the data sooner. But it is what it is. What it means in many cases is that the data isn't necessarily actionable given its timeliness in the way that we might like it to be. Again, just as a reminder, even though we only gave you, I think, 6 records or whatever number we gave you, that there were 65,000 records in each file. So not exactly something that would be easy to manipulate, you know, on its own. In fact, that would probably be bigger than the typical spreadsheet applications. I think they upped the maximum, but I believe it used to be around that. This is what it looks like, and you guys had a chance to look at this in, you know, in your packet that we sent you before this session. I'm just going to walk through it really quickly. The beneficiary ID is essentially their plan number, their subscriber number. The from and through date describe the dates of the procedure. In this case, there's an error. There is an error in one of the through dates, but in essence, these are procedures that typically occur because they're office visits on a single day. They would not have different dates. So please disregard that error. I just noticed that. It tells you how much was paid by the plan. That's the payment amount. And by the patient. That's the beneficiary amount. The RFR number is a referring physician NPI number. And then you've got your ICD-10 diagnosis codes and your CPT code. So based on this data, for this individual patient, we can tell that this patient has been to the hospital for a number of ER visits over the course of time. 5 ER visits of different intensity, level 2s versus level 3s. That's information you can glean from that CPT code. I'm going to just turn it to you folks. I'm curious to hear what your initial reaction to this is. Is this something you currently do? Is this something you have any interest in interacting with? And where would you want to get started? What I always used to say, what are the questions that you would want to ask this data set? Is someone willing to kind of tackle those questions for me?
Right, this is Mike with Worcester County. We're kind of looking at, you know, this is something we do sort of in-house from time to time, and we do kind of look at these things. So, you know, some of the things I like here is, you know, really looking at what procedure codes are you doing that are kind of your most prominent, the ones that you're doing the most often, sort of also the ones that are the most money. Same thing with diagnosis codes. You know, which diagnosis codes are we treating the most frequently? Looking at what procedure codes are we using for each diagnosis? Is there a particular procedure you tend to do a lot with the different diagnoses? You know, I like the referring MPI. You know, you can look at that and see, is there, you know, different referring physicians that refer kind of for different reasons or tend to refer for different reasons, which could lead you to maybe want to go back out and talk to the referring physicians to say, you know, hey, I notice you don't refer a lot for this thing. Don't forget that we do this service and we can treat these people, you know, and those types of things for marketing. But yeah, those are kind of our thoughts on it. A lot of stuff I think that we glean for it.
Yeah, excellent, excellent. Anyone else want to add some thoughts?
We use data similar to this with a couple other attributes for our level of care. We have, you know, the MDDO level and then advanced practice level, whether it be a PA, a nurse practitioner. So we kind of look at, do we have everybody in the right level of care? Can we use the members of our medical team any differently or more appropriately based on some of the things that we're seeing?
Great. Excellent. Is anybody currently getting complete claims data from any of their plans, or is this kind of beyond where most folks are at this point? Since no one's volunteering, I'm going to assume that most folks maybe aren't getting this. It's important to understand, I'm going to talk you through some of the other scenarios that we would typically use this data for. It's important to understand, too, that this isn't just what we build. You know, because a lot of organizations say, well, I have claims data because I can go into my practice management system. But this is the data that everyone builds for our patients. So I'm going to take you through, and I'll talk a little bit myself about some of the analyses that we see groups using this data for. And I think you guys hit on some really important ones. But let me take you through a couple of others. I think that doing an analysis very frankly of the referring NPIs and identifying who do you share these patients' care with, and do you have the appropriate relationship you need to be doing that effectively is one way of using this data. Identifying folks who are utilizing services that essentially are not linked necessarily to value. So if you see a lot of high utilization of certain high-cost services that are potentially avoidable, like ambulatory sensitive conditions, is another avenue for exploring. Even just the basic summing of the data grouped by patient to identify which patients are costing the most is an important analysis that organizations undertake. They also, we've seen organizations undertake entire initiatives to improve their own diagnosis data because if it's coming through as claims on from other providers and we don't know about it, then that could represent a clinical problem and even potentially a patient safety type issue. So there's a lot that can be done with detailed claims data. The challenge with detailed claims data is, of the 3 data sets we've looked at so far, it is by far the most challenging to manage. You've got, the largest number of records. You have a lot of deduplication issues because you're getting 12 trailing months every single month, so you have to know how to work with that and match it up. This is the only data this particular organization receives from the plan. So hidden within the data is their actual attributed population. They have to identify the unique provider numbers, and then you notice that there isn't some of that same useful information that we saw in some of the other data sets. So it really does present them with some unique challenges in terms of how to put it to use, and frankly requires a fairly robust team. This is really the key, though, is that they find this data to be very helpful in better understanding the usage patterns of the population of patients that they serve. A lot of things quickly come to light that really make it possible to better understand their population. From a business planning, care planning standpoint, for example, identifying procedures that maybe you should move in-house because there's a prevalence of use, or sometimes identifying patterns that demonstrate that maybe you aren't being as efficient or effective in your care. That's another avenue of exploration. So can we do a better job of keeping people with chronic diseases out of emergency rooms, for example? I believe, if I'm not mistaken, the patient I chose was a diabetes patient. So again, you would have seen, I think, diabetes and hypertension. So utilizing an emergency department for those reasons, generally speaking, are something that we could work towards reducing, trying to get the patient on a better care plan, helping them understand their options for getting care when they're not feeling well, etc. But I can't underscore, again, I'll talk quickly about it, I did mention it earlier, that it's pretty challenging to work with this data. Interpreting it, understanding it is a skill set that most folks working in a health center don't necessarily have. So it's a powerful tool, but it does require an even more robust data management skill and ability. This is one where I mentioned earlier a real database server type approach is probably required. You're probably not going to do too much manipulation of this data in basic spreadsheets. It's very sensitive data and information. It's all protected health information. So wanting to make sure you have security and privacy covered in terms of how you take this data in, share it, and use it throughout the organization really does require a more robust set of skills. So I'm going to, before I move into the discussion of how we see groups getting the most out of data, I wanted to stop and kind of ask you one last time, if anyone had comments or questions about detailed claims. We feel it's going to be such an important tool at some point for most providers to be able to use and interpret and understand this data. It's certainly a evolving and emerging skill, not one that we think is in place in most organizations. Any final comments or thoughts from you folks? Okay. Well, I'm going to move into just a quick discussion of how we see groups getting the most out of their data. And then we're gonna assign out some homework for you, really easy stuff, just like last time, and we'll get you on your way, hopefully right on time, maybe even a little early. So when we first start working with groups that look to make the shift to value-based reimbursement, we actually usually do an inventory of the data sets that they have available to them to support this kind of work. And that has led us to a variety of best practices that we want to share with you. The first is that detailed data is always better. That is not to say that if you don't have the ability to manage a detailed data set, that it can't be very challenging. However, what we often find is that payers typically move in the direction of less data, and we try to move them back in the direction of more data. Given the option of the 3 different types of reports, I would always choose the detailed claims file data. I would try to get my plan to increase maybe the identifiers on that data to make it more actionable and interactive. I might try to get it sooner rather than later. But I can always go from detailed down to summary. I can't go from summary to detail. Even if you're not ready to manage detailed claims data, it's always better to negotiate for it ahead of time. It's one of those things where when you're exploring the possibility of taking on any sort of risk, whether that's just some upside risk or some pay for performance type risk, that's really the point at which you have the leverage to ask for this information. And if you simply assume that the payer is going to have a program or a vision for what type of data they're going to share with you to make the program work, you may be mistaken. You may actually find out that they didn't have that plan all along. You're going to want to think about a couple of other things in terms of the level of detail. So what are your matching identifiers going to be, so that when you get the data, you can actually do some direct reporting and hashing off of it and not have to do that manually. Make sure that you understand how to handle the changing data month to month. For example, data from previous periods that arrive late. What do I mean by that? Well, Medicare, for example, has a 12-month claim runout. So you might get a claim in your data file that's 6 months old that you don't get for, essentially for the first 5 or 6 months. It just shows up in the claims file because it was submitted and paid way late. And so handling those kinds of exceptions can be challenging. Having a process for assessing the impact of all data on eligibility for gain sharing contracts. So what I mean by that is know the rules of your contracts, know what you get paid for. In the second example, we talked about how if patients fell off the eligibility at any point in the year, they were ineligible for payment for the annual bonuses. So knowing how that works, knowing what you can do about it is critically important. You will need any and all available demographic data and a process for dealing in inconsistencies between your own systems. What I mean by that is just try to get as much patient identifiable information into those data records so that you can do the best job of matching that you can. realizing that you're going to find some interesting things when you start comparing these data sets to your own record-keeping systems. Mismatched names, mismatched dates of birth, patients that aren't in your systems at all, patients that are in your systems but not on the list and you feel they should be. So having a plan for how to deal with that is going to be important. Get data frequently. We think that monthly is the best. Certainly if you could get it sooner than that, that would be amazing, but monthly is definitely kind of the benchmark to shoot for. The data that we'd love to get our hands on a weekly or even daily basis that's tied to the attribution process would be pre-authorizations for hospital-based services. So tell me before the patient is even admitted that they might be admitted to the hospital. Not everybody can do that. Not every plan can do that. But when they can, we can actually make things even more actionable. Monthly data should ideally identify which patients have been added, which have been dropped, and which have had key information changed by the payer. Again, that second data set group, that was one of their key challenges, and they had to create some workarounds because the plans didn't give them that. And it should be delivered in a timely manner based on contracted terms, meaning if you sign a value-based reimbursement contract, it should have the terms in it of what data you're going to get when, and it should be in a predetermined format delivered by a secured vehicle. So you really want to be working with payers that have thought this stuff through, but if they have not thought this stuff through, you really do need to be the one to make them make a commitment to you in terms of how it's going to work. Data practice number 3 is know the rules, and really this gets kind of embodied in the various reports that you're going to write that are going to support the work that you want to do with these patient populations. So one of the first things, and you guys kind of hit it the nail on the head right out of the gate, knowing which patients are eligible for which contracts is kind of a panel management exercise, and you've done a fair amount of panel management work in other arenas. Understand how lapses in eligibility impact participation in contract. If the patient isn't eligible at any point in the year, does it make them ineligible for payment? Which payments are going to appear in the denominator of which quality measures? And whose data rules? Does the plan's data ultimately determine, for example, whether a patient has diabetes based on their ICD-9 code of the billings, or is it your record that would determine that? If there's a discrepancy between the two data sets, for example, if you have documented a certain test that would qualify for the numerator of a quality measure, but the plan doesn't have that data, how do you get them that data? What do you have to do to make them aware of that data? Are there rules specifically defined for data discrepancies? Understand what options you have to remove a patient from a panel. That's not really our preferred way of kind of improving our scores, but there are valid reasons to have a patient removed. How do you do that? Who within the payer organization needs to be notified? Is that a formal process? And how do you essentially initiate that process? How do you add patients? Do you have options for adding patients who do not appear on the list but are utilizing your organization? This is a strategy that most organizations undertake when they enter into value-based reimbursement, is they try to enroll more patients because they want those contracts to provide the resources that they need to essentially care for that population. But if a patient shows up, isn't in your contract, isn't showing up in your attribution data, but wants to use your organization for their care, do you have options to add them to that list through some mechanism? And lastly, what options do you have for outreach? You guys kind of hit on, having the phone number and contact information is good. What are your other strategies going to be? How are you going to use the information and put it into action? Through what mechanisms? Best practice number 4 is risk stratify. Attribution is really the first opportunity to begin allocating resources to your value-based strategies, your quality improvement exercises, your population health exercises, and doing some basic risk stratification is helpful because it immediately gets you started thinking on how to allocate resources differently in pursuit of a healthier population. Stratification will determine the administrative and clinical pathways that a patient will go through. For example, a new patient known to have multiple chronic diseases should be prioritized for outreach and care coordination, whereas a person with low risk may not receive the same priority for those types of services. The leading organizations, the ones that are doing this really well, are using payer risk score, counts of chronic diseases, known social determinants of health in their electronic health record system, and a variety of other methods for stratifying patients. So it's great to get a list of 6,000 patients. It's better to get a list of 6,000 patients and know which ones have which diseases. Lastly, and this begins kind of the shift to a discussion about activation, which is going to take up the majority of the remainder of the education in this learning collaborative, do your outreach in relative real time. So you should be outreaching to patients who have been attributed and have not been seen. We obviously don't know exactly what's going to happen with the Affordable Care Act, but in many of the insurance programs, patients are eligible for wellness visits. If somebody's on your list and hasn't had a wellness visit, get them in for one, because that's one of your best strategies for helping them, rather than waiting for them to only see you when they are already very sick. Outreach should be prioritized based on however you stratify risk to allocate resources to the patients with the greatest needs. You need to track those outreach efforts as they are essential to proving that a reasonable effort has been made. Many times, the only way you can actually get a patient removed from your list is if you demonstrate that you've made various attempts to get them into your practice. But we're going to talk, and so this wasn't meant to be a full discussion of activation strategies, because we are going to be talking about activation in much greater detail in future sessions. Back to you folks. Any questions on those best practices, anything you want to discuss, or any comments that you want to make? Okay. Well, with that, that brings us to the end of our education for the day. We would like to hear from you folks, and you have a link to a survey, both to give us some feedback on the educational content today, as well as to answer some questions that we're curious about. We'd like to know a little bit more about you and how this information is or isn't relevant to the work that you do. Sounds like somebody put us on mute or hold. AJ, are you able to do anything about that music? Okay, perfect.
Yeah.
We'd like you to answer some basic questions like, what does patient empanelment mean in your current practice? Do you match patients with a designated provider within your organization? What challenges have you had with patient empanelment? Do you think your criteria of who your patients are matches your payer's definition? Do they assign you patients you've never seen, for example? And what methods do you use to engage patients in their care? Just some basic questions we'd like you to think about to give us a little feedback and help us better guide the discussion going forward. With that, I will stay on the line for a few moments if folks have any questions that they want to ask. Otherwise, as always, you can feel free to reach out to us at any point between now and our next session via our email addresses. Any